Okay. We need to make sure that we're paying attention to everything. Okay. Is it giving you guys like the full screen, or are you getting the presenter mode stuff?
I can see your full screen,
Okay.
like the presenter mode. Well,
Okay, I don't want to show presenter mode. I want to show just sharing. That's better. Okay, so now are you just seeing the PowerPoint? Just the one slide?
nothing yet. It just says you're sharing the screen and it's black. Now it is.
Okay,
It's the PowerPoint.
just the one slide?
Yeah.
Okay, perfect. Okay, too much technology for Monday morning. All right, so we're gonna start with George here. And George, he has COPD, urinary incontinence, hypertension in the beginning stages of Parkinson's. He is independent and alert and oriented ×4. He enjoys sitting outside and visiting with other residents. So of this information, what's the important information for you guys? What do you pick out?
COPD.
Okay.
Alert and oriented.
The Parkinson's and his hypertension.
Okay.
Going with a cigarette, if we're supposed to incorporate that.
And his oxygen.
Yeah, I mean, he's got, what of this is immediately concerning?
From the picture or from what we're getting?
Both. You're getting all this information, right? We're visual and
the cup of hot coffee with the cigarette and the oxygen and Parkinson's.
Yeah. So he's kind of an at-risk dude right now, right? What are you worried about happening to him?
Explosion and burn.
Burn up.
Yeah, burn. Where would the burn potentially come from?
Probably first that cup of hot coffee.
Okay, the cup of hot coffee. That's an interesting one. People don't usually pick up on it, you know, because they're like, yeah, coffee, no big deal. But we do have burns from coffee. Where does coffee usually get spilled?
In your lap.
Yeah, in the genitals, in the lap. He's urinary incontinent. What's he probably wearing?
A pull-up or a brief.
Yeah, pull-up, brief, some sort of incontinent pad, right? So something to think about is when we have people that have burns, what's something, or spilled hot stuff in their lap, what's one of the things that we need to do?
Undress them.
Yeah, we've got to get that off. We get, the burn unit gets a lot of people with really bad groin burns, both babies and elderly, because they spill hot stuff in their laps, and they have diapers or briefs or whatever that's holding that heat in there. And the genitalia don't have quite as thick of skin as the rest of our tissues do. And so we get some really significant burns down there because of coffee, you know? And so that's why you'll see, like, I think Gateway says, like, put 3 ice cubes in the coffee before you give it, because they know that this is an issue. So yeah, I mean, definitely, I mean, we got a cigar going on here. We've got hot coffee with Parkinson's. Now it is early on, like it's beginning stages. So, you know, the Parkinson's isn't as big of an issue, but definitely we've got cords and tubing and stuff. So good.
It's coughing from the COPD and could lose like the coffee cup and risk thermal burns.
Yeah, absolutely. Even just with the COPD, with the coughing and stuff, he could be risking thermal burns or any of that kind of stuff. So just, I mean, huge issues. But you know, he's just sitting out chilling on a good day right now. Okay. So now, let's see. How do I get it? There we go. So now, excuse my coloring here, but so when people have oxygen on and they're smoking, we'll see like a flash burn to the face. And when we get that flash burn, it looks like a butterfly kind of on that bridge of nose area. And so you can kind of see with him, he's had that kind of burn. What information do you want now?
Like his respiratory status, like is he breathing? Is he alert?
Yeah, so like he's still alert and oriented, he's breathing okay, definitely a little more swollen in the nares and the lip. You know, he's got some swelling kind of down on that other lip happening. Any other information that you want, or you ready to put your action in?
Erin, I have a quick question if I could.
Yeah.
Okay, like I've seen them, you know, where they came into work where they've like smoked at home and had the burns on their face
Yep.
from like oxygen and stuff. But does it, like, you really have to excuse my ignorance on this, but does it follow the nair? So is like the inside of like the lining of his nose burnt too, or is it just the face?
Yep. Everywhere that oxygen goes is what's going to be burned. So yeah, they can definitely have it go up into the nasal passages. So that's why you would see a lot of the swelling of the nares, because the inside is burned. We can also have inhalation injury. Was he sucking in? Was he like lighting up and sucking in as he was doing? Because then you have that inhalation injury down into the trachea, down into the lung tissue itself. So a lot of times with burns, what we see is actually the very little of what's actually being what is there. Usually it's sort of almost like a bed sore or pressure ulcer, right? That's just, we see that surface piece, and then what's underneath is so much more. Rima, do you have a question?
Yeah, with this type of burn, can you put ice on his face, or no ice at all with any type of burn?
No ice ever.
Okay.
No ice, period. Never, never, never. Never put ice on a burn. You will turn a burn from a hot thermal burn to a frostbite burn if you put ice on it. So we don't ever put ice on burns.
We used
So-
to put
What?
we used to put toothpaste because my grandma always said the menthol in the toothpaste will bring out the heat, will draw out the heat. So we always put toothpaste.
That would burn like a son of a gun, I would think.
Right? We were young and dumb.
Yeah, I know. We all
I
do.
have put toothpaste on my hands when I burn them, and it helps, and also tomato paste.
Yeah, I know toothpaste because they say like the menthol will draw it out, whatever. But
Wow. Yeah, I would not recommend any creams unless they are specific burn creams.
like a Silvadine.
Once you get the burn healing, then we can do some lotions and stuff, but I would make sure that we're using whatever the facilities prescribe. But yeah, tea is probably as adventurous as I get with burns. If you put black tea or tea on, I'd make sure it's not a mint tea. That works really well to pull the heat out, just like it does for tea pads when we do for moms that have just had babies. So we'll do tea pads, same kind of thing. Okay, so we've talked about that he's swollen, got swollen nares. He's breathing okay right now. What do you want to do? What's your action?
Take a cigarette out of his mouth.
First off, get rid of the cigar.
Right, got to get that cigar out of his mouth. Okay. Why are you taking the cigar out of his mouth?
Go ahead, somebody else, because I'm a smoker, so I'm gonna like come up with an answer that I probably shouldn't.
I think you
Just
just need to
I don't-
clear everything out of the area because you need to assess him. So you need to take off the nasal cannula, clear the glasses and the cigar so you can see what's going on.
Okay. Yeah.
Get a
So
good vision.
And
definitely
prevent
want
further
to assess.
injury.
What, Lakeisha?
I said prevent further injury.
Yeah, prevent further injury, prevent blockage in case that airway is starting to swell, or if he like bit off the tip of the cigar and it's down there in the trachea. I mean, we don't know exactly what happened. that caused this, but we definitely need, so prioritizing that airway. What are you gonna do after that? So we've got his airway, great, we got his airway good. Now what are we doing?
Should we listen to his lung sounds?
You could, but is that really an issue right now?
You said he was alert, so I guess, I mean, I could check a pulse, but if he's alert and, I mean, it's a pulse, there's a pulse there.
Yeah.
We could call the
ask
doctor
him
and
questions
see
to-
what he wants.
So
Go ahead,
what,
Rim.
what, Rima?
I said we could call the doctor and see what he wants us to do.
Probably, you're probably gonna want this person to go somewhere. Is your facility gonna wanna continue to take care of him?
Probably not go to the hospital.
Right. We probably want him to go to the hospital and get seen. So, you know, after you kind of cleared out that airway passage, we probably want to get him to the burn unit, or at least get him seen by a burn physician. So again, stabilize, transfer, get them to where they need to go. That's how emergencies work all the time. Even in the ICU, if we can't stabilize them, if we can't take care of them, we have to transfer them out. And I've had to transfer several patients to like UNMC or Children's Hospital or stuff like that. Get them to the level of care that they need to be. Catalina, you brought up listening to the lungs. What were you going, like, what was your thinking, or what was your purpose behind it?
I don't know. You said if there was swelling out. I just was wondering how far the swelling was, and like, was his lung sound like awful, or like, you know, I don't know.
Yeah, no, that because what's something you're listening to, not necessarily the lungs, but you're definitely listening, right? When you're walking in and assessing, you're listening to what's going on. Like, is he making a straight? Is he breathing like? Because if he's breathing,
I'd
with
imagine like if his airway is like, I mean, if his nostrils are swollen, like how far does the swelling go? Is like, is his like down, his down like in his airways like that so swollen that there's like, I'm just imagining like he's like, if it's swollen, like it's like he's breathing out like a little opening like a straw or something.
right, yeah. So that's going to cause that stridor sound, and that's a really good thing to assess. I don't think you would really need a stethoscope to assess it though, and so that's why I wanted to dig into like why you were thinking it, because yeah, definitely you're going to be wanting to listen to what's going on with him. If he can't talk to you, because you know he's alert and oriented, enjoyed visiting with people, so he's a talker. He's just kind of does his own thing. So understanding that, you know, you may not have a stethoscope on you. You might, but that necessarily, not necessarily listen to the lung sounds, but to the throat and to that stridor. So you wouldn't necessarily need a stethoscope for that. So yeah.
I saw Joe where like they just kind of like put their ear up to his chest and like up to the person's ear, like.
Yeah. So yeah, you might take your ear and kind of put it next to him. Just be like, okay, am I hearing any stridor? Again, that stridor is going to be much more in the throat. We don't really hear the lungs when we have inflammation in there. You know, you might hear some wheezes and stuff like that, but really it's going to be in that throat first, in that trachea area is where that's going to get to, because the epiglottis, if it does its job, it's going to snap shut so that nothing gets down into those lungs. But sometimes it happens so fast. That's why that time gets to be so important. If this were a house fire and he was stuck in a house fire, then we're worrying a lot about the lungs, because your time of exposure is so much more. So that's something to think about as you're working with these patients. If something happens, he's out on the patio of an assisted living center. Assisted living's not going to want to keep him, right? They're going to want to ship him. So that's the other thing you have to think about is, where am I? What's my location? What access, what supplies do I have? Because depending on where you are, depends on the supplies you have. And in assisted living, you don't have very much. You're going to want to ship them out. So, and just even, you know, if his burn wasn't that bad, maybe you just send him to like an urgent care. But with facial burns, we always want those usually in the ER, because we want to see them. Like, we want to make sure. So would we have to necessarily do fluid resuscitation with him?
Maybe not.
Okay, why not?
It doesn't look like he like is significantly burnt enough to have lost lots of fluid.
Yeah. So with him, we're probably not doing fluid resuscitation. And if they do, maybe it's like a liter of fluid just to keep him hydrated. But unless that burn really is extending down into that nasal passage and down into that trachea, he's not, I mean, he's going to have some real significant swelling here shortly. And so we're going to want to make sure we're managing that airway, but probably not fluid at this moment. Right? So good. All right, so let's move. So we are going to talk about a little bit more about burns. Go. There it goes. So those are what we're going to talk about. So we're going to put two things together. This is a young lady who, thank goodness, shared her pictures on the internet. So, because usually the burn nurse gives us all sorts of good, gross, gory pictures. But she actually had a seizure and fell into some sort of like patio heater, is what it says on her blog spot. So what kinds of things are you worried about at this moment for her?
Just from looking at her?
Yep.
Her blisters to pop an infection.
Okay, so we've got blisters. So what do blisters tell us?
It's a partial.
Okay, so we've got a partial thickness burn, right? So this is decently deep. Okay, it's on her face. What are the things that you guys worried about?
Pain.
All right.
Okay, pain, because yeah, that,
I don't know, maybe like some, I don't know.
yeah,
I'm worried.
that eye,
I'm worried about her airway just because there is facial swelling.
yeah. So, and this is probably first when she just got to the ER. Okay, so we've
What
got,
about her seizures? Is that a new thing, an old thing?
okay, so the seizure, is that new, old, what caused it? What's, like, was she drunk and had a seizure, or has she had seizures before? Is this something new to her? And actually, she hadn't had seizures before. So seizures is new to her, and then having a seizure. So think about, here real quick, think about also time and temperature. How long was she exposed to it? Because what does a seizure do? Like a seizure leaves you unconscious for a while, then you have your post-ictal period. So we don't know how long she was exposed to this fire, how close she was to it or whatever. And we definitely have some issues with the swelling. She's got partial thickness. I'm curious if under her eye is going to end up, or if up here where there's not a blister, kind of between the two blisters, I'm wondering if that's going to be a full thickness burn there. And the blisters, because usually burns have kind of almost a target, right? There's usually the area that's burnt the most, and a smaller area, and then a bigger superficial area. So we definitely have a ton of issues. And when we're talking swelling, that's the swelling we're talking about. Okay, so this is probably about 24 hours or less than 24 hours later. Okay. So when we're talking swelling, now you can see the significance of the swelling that people have with burns. Okay, this is why we have to do fluid resuscitation. This is why we have to do, this is why they go into like a hypovolemic shock, is because they lose all of that vascular fluid out into this third space around the face. Okay, this will go down. They don't stay this swollen forever, but the body is. So now you can definitely see you've got, it looks like probably full thickness right above that eyebrow where it's white and leathery. You've got partial here where those blisters kind of were, and then you can see kind of the ring of light pink, which would be the superficial. Probably on the tip of her nose is another area where we had a partial thickness. And the problem with burns is you can convert if you give the wrong amount of fluid, if we give the wrong medications, if we do things wrong, we can actually convert this full thickness, you know, to a much bigger space. Like any of those blisters, those can still convert over to a full thickness burn because the tissue is continuing to be damaged. So that's something really important for us to understand. Fluid resuscitation is important, but too much is bad and too little is bad. So we're really going to pay attention to it. And then here's what it ended up looking like. So looks like we have potentially some skin grafting that they took. I don't know if they took from her nose and put, but I mean, you're looking at some pretty significant injury here for her. So, and those eyelids make me real nervous if she's gonna lose her eyes. And she actually didn't lose her eyes. Then she got the fun of being diagnosed with epilepsy on top of all this. So she ended up having to go through like an EEG, which we kind of talked about when we talked about head trauma. And she ended up having to get put on epilepsy meds to keep her from having epilepsy. So this healing process takes a significant amount of time. You can't do this, you know, this is weeks and months of healing skin grafts and all that kind of stuff. So kind of interesting, poor thing, just that's a really stinky area to get a burn. So any kind of questions on burns?
I have a question.
Yeah.
So like for you know, like the formula we do with burns. So like say you come in and like your burn isn't even like really severe and like say it's like 15%, like would you still give fluids no matter what?
Nope. And if you're only 15%, is that partial or full? You know, like that's the important stuff. Like you do not give, like sunburns, we encourage you to drink more water, but it's not to the same level and same degree. Like that she needed, like this young lady probably needed some fluid resuscitation, but she didn't need a ton, right? We probably were giving her a liter of fluid or so just to try and make sure she's staying hydrated as that body shifts. She's also young, so she can adapt. So, and then think about what are we gonna be watching while we're doing fluid?
For urine output,
Urine
like to make sure that
output.
knees are perfusing.
Yep, we want to watch for that urine output. The other thing we're going to be watching is definitely our blood pressure. If her blood pressure is tanking, then we're going to be trying to figure out, we're going to be adding more fluid to her to try and keep that blood pressure up. Rima, do you have a question?
Yes. So with severe burns, I've heard that patients die 3 to 4 days after the burn. Why does it take 3 to 4 days for them to pass, not the first day?
That just depends on what got burned and how, like severe is kind of a relative term. I would consider this young lady's burn pretty severe, but not necessarily life-ending.
Like half of the body.
Because you're looking at, usually they die from the like fluid shift and damage to organs, and they were just, if half their body was cooked, that's what you guys have to understand. Like sounds really gross, but if you like a rare steak, that is a not very burned food, right? The inside is still not very cooked, versus if you get a steak that is well done, it is cooked all the way through. So that's what burns are. Burns are literally cooking tissue. So it just really depends. But yeah, I mean, burn patients, I've had one that stayed alive for 6 months and then finally succumbed to sepsis and infection, because you have to think about, what does our skin do? Our skin protects all the inner organs from infection. It thermoregulates, and it helps us keep our fluids in. When we have burns, all of those things go out the window. if someone's dying in 3 to 6 days, they're probably not dying of infection because infection takes 7 to 10 days to really set in. So if somebody's dying from burns in 3 to 4 days, they're probably dying because so much of their body was damaged and the organs aren't functioning. I mean, if your kidney's cooked, it's really hard to get that kidney to function again. Our biggest goal usually with burns is to maintain and support. We're going to debride as much tissue off. When they're in the burn unit, like if you're in a facility with someone, don't start debriding tissue off of them. Let them do that in the burn unit because it'll be sterile. They'll have all the right supplies and equipment, and they'll have the right pain medications. Like we do not have the right pain medications. So you're going to want to send them somewhere. But yeah, if they're dying in 3 to 4 days, it's because the burn did so much damage to their inner organs and their body just couldn't regain and work. So, but infection's going to take a few days. So like, that's one thing when we're thinking in that priority list, infection is not usually for burns. It's in there, but it's not usually that first day. Like infection becomes my issue with the young lady in the middle, right? That's when I start being worried about infection. You know, the one where she's in, you know, just has the blisters, I'm worried about fluid, I'm worried about airway, and I'm probably worried about tetanus because tetanus shots are really important to get patients because burns seem to be really dirty. So she's probably getting a tetanus shot, she's probably getting fluids, they're probably going to watch her airway really well. In this one, you know, a few days later, we're now worrying about, now you've got all this burn tissue that's open and exposed. Now I'm worrying about infection at that point in time. I'm not really worried about thermal regulation a ton with her because she doesn't have a lot of body surface area that's been burned. You know, think about if you've ever gotten a sunburn over your entire back, how chilled you get. Okay.
So
I get the question.
What's your other question, Rima?
So with tetanus, do we have to look at their history and see how long ago they had a tetanus, or do we just give them one?
If you have access to their records, absolutely, but otherwise, just give it.
So even if they had one in like 6 months ago, will it affect them in a bad way?
No.
Okay.
I don't think so. I mean, you're gonna have to get a doctor's order for it. So, but if you don't know, they give tetanus shots. But you know, if you had to choose, like in the girl in the first picture, what's my priority for her? Tetanus is on there, but it's low level. Like it's not, because it's a facial burn, I'm really worried about airway. I'm really worried about saving that eye. You know, the other thing is does she have contacts in? Something to think about. Are you going to be able to get contacts out of her eyes in that second picture?
I have a question. So you know how you said if they have blisters, we're not supposed to pop them. So like from the first to second picture, like do you think the blisters just popped on their own?
I think burn debrided it.
Okay.
Yeah, because looking at how clean that is, I think burn went in and did INDs on her face and did some scrubbing. So we don't pop because blisters keep stuff sterile.
Yeah.
And once those pop, now we put in a bigger infection risk on her face. So, yeah, I mean, definitely has some issues.
Contact actually like melt to the eye?
Not that I've seen, but I mean, if your eyeball's probably that cooked, your eyeball's probably gone anyways.
Yeah.
But yeah, that's one thing with trauma patients or anybody, if they have contacts in, we want those contacts out as fast as possible. Because if this also had been a chemical burn, contacts will hold the chemical in the eye more. And they have like little water lenses that look like contact lenses with IV tubing hooked up to them to help flush out eyes. They're super gross.
Oh, wow.
So,
Hey, Aaron, are you recording this? Is this going to be like available to watch again?
yep.
Okay.
So. Somebody put something in the chat and I can't get to it. Where is it?
It was me. I was just trying to ask a question. Like everyone was talking, so I just like typed it. But
Okay.
I guess it was more like with the first patient. When you said he's like alert and oriented, so I read in like one of the books like about obtundation.
Yeah,
Like,
obtunded.
yeah. Okay. Is that only with trauma, or is that like related to burns? Or
Nope. Usually your burns will be alert and oriented and they'll be awake. So unless the trauma happened, unless they hit their head or they have been like in a, like, again, it's about that time. If they've been in a house fire and it took an hour to get them out of the basement of the house fire, it will, that's when we're going to have to worry about like whether they're alert and oriented. And that's just because they've sucked in so much soot and carbon monoxide and all the ash and everything else, all the smoke inhalation.
okay.
So normally people are awake when they get burned. I mean, obviously like with her, she had a seizure. So she may not have been super awake when she came in, but that's not because of the burn, that's because of the seizure and she's in a postictal phase. So that's one of those things. If you ever have somebody that comes in with a burn or they come to you with a burn and they're not awake, then that tells you that there's something else going on. Either they were drunk and passed out on a fire in the campground, or they took sleeping medicine, or they've been in a fire for a prolonged period of time. And so then we have like almost a hypoxic issue from it. But otherwise, most normal people that get burned are going to try and get out of it, and so they're going to be very awake.
Okay.
But there are the people that, so if they're not awake, you have to, then your head's triggering, okay, I got to deal with the burn, but I also have to deal with why aren't they awake? Okay, so that's something to think. Good question. Yeah, obtunded or obtundation. I don't know, funny word. But yeah, not being asleep. If they're asleep, there's something else going on. Okay. Any other questions for burns? Basically, maintain what you can, stabilize them, and get them to where they need to be. Because, like, unless you're working in a burn unit, you want to get them to where they need to be. Okay. So, all right. So now we're gonna work on Fred here, and so, huh?
Can you hear me?
Yeah.
So I just joined and I'm kind of late. I apologize. Okay, so the priority, would it be fluid and electrolyte for burn?
Jen, why don't you, because I talked about it and then I'll video this. Okay. So just watch the first section of it so that it gets you caught up with everything, okay?
Sounds good.
All right, cool. So we're gonna work with Fred, and you are a home health nurse doing a home visit, and Fred's had a post-abdominal procedure. He lives out on the ranch about 75 minutes away from town, and this is how you find him. Okay. What more information do you want?
How long has he been
How
there?
long?
Okay. How long's he been down? I don't know. He's not really responding to me.
Oh, does he have a pulse?
Okay. Yes. Right. So, yep. So we're going into that, digging into that information. I want to know, does he have a pulse? What other things do you want to know?
Is he breathing?
He's hurt.
Does he have a head injury?
Okay. Head injury. Is he hurt? Like, you're going to go in and start kind of digging into that assessment data, right? Are you going to move him right away?
No.
No, just kind of leave him be as much as you can. Okay.
Can you like lay him flat but like secure C-spine?
I wouldn't lay him flat until you know what's going on, until you have an idea, because if you lay him flat and his tongue is swollen, then you've just caused that airway to block. So always go in, gather your data, gather that information, dig into what's going on, like look around the scene. Obviously you've got stuff that's all over the floor, so it wasn't like he just slid down, right? And he obviously doesn't have pets that eat his crackers, so but we've got some sort of issue going on with him. Okay, so here's some additional information. He is breathing, he's minimally responsive, he groans to painful stimuli. See who's got me echoey here. He's pale, and he has a thready, fast pulse. So at this point, what's your priority?
To get the ambulance called.
Okay, definitely want to get some help there. Okay, because how far are you from getting help?
Is it 75
minutes?
Yeah, you're 75 minutes, so you're out a ways. Okay, so we're probably gonna be calling the ambulance. After that, what do you think you want to do? What's your priority? So what I want you to do here real quick on a piece of scratch paper, I want you to put the important information in the middle and then come up with 3 priority concepts. And then be able to tell me why you picked those 3. Oh, that was a long song. It was dark and I was over until you kissed my lips and you saved me. My hands, they're strong, but my knees will fall too weak. Standing in your arms without falling to your feet. But there's a side to you that I never knew all the things you say they were never true in the games you play. You would always win, always win. But I said, delay, what's it for? And I said, waiting for when I cry, 'cause I heard it scream when I
Love me some Adele. Oh, love it.
I'm gonna give you about 30 more seconds. All right, and I'm gonna put you guys in breakout rooms, and I want you to discuss, what do you think about, like, share what your important information was, and then your priority and your action. All right, so I'm gonna create rooms here. Let's see if it'll go. I'm gonna open them. So it should have sent you some sort of invite to go into a room. So go ahead and join them. And I'll give you 5 minutes. Lakeisha, can you hear me? If you want to, does it show you that to join a room?
Yeah, I was just on the phone
I-
with the health department, so I missed that whole conversation.
Okay, just we're just looking at Fred here and just talking about his priorities. So if you want to hop into your room and you guys are discussing it for about 4 or 5 minutes here, and then we'll come all back together.
Okay.
Okay.
All right.
Oh shoot. Oh, we got one. A couple coming back.
Casey, your dog is so cute. I literally just saw you pop up on the screen for 3 seconds and I saw a puppy in your lap and I am crying. I love that. That is so precious.
People should be coming back here in about 20 seconds.
Okay.
Getting this whole Zoom thing figured out. All right. Okay, is everybody back? All right. So I'm gonna launch a poll. We'll see if that shows. Is there a poll that shows for you guys?
Yeah.
Yeah.
Okay,
Yeah.
go ahead and answer. Which one did you pick as first? I got a couple more. One more person to vote if they can. All right. So I got a lot of people that picked airway gas exchange first, like 68% of you. So 13 of the 19 picked gas exchange first. For somebody to pick that first, what was your thinking behind that?
He was pale. And I feel like it's always supposed to be your first thing if you come across like something like this to check that they're breathing.
I just kind of went, yeah, I kind of did like the safety because we kind of talked about that in our breakout group.
Okay.
And the safety that a situation was assessed. So I automatically moved on to my next, which would be airway, then breathing, then circulation. I just
Okay.
kind of is my rationale.
All right. He's breathing.
Okay.
You still have to like assess it.
I
Like,
mean, how do
So
I
you
know if
assess
it's not
it,
like
but
favored?
once you get that information that he's breathing, is it still your priority?
Can't ABCs because we know his airway's okay, he's breathing, and now we
Right.
got to work on perfusion.
So, but with the information you have, breathing isn't a priority anymore. Like, I mean,
No.
you're gonna always be there, but like when you're
That's what I'm
thinking
saying,
about
like-
like your airway, he's got it. We've got breathing. Okay. That's where in emergencies, it's you guys, airway and breathing are not always the right answer. They're not always the first thing we go to. If someone's breathing, if I had said he was agonal breathing, then absolutely. You know, so it's you're gonna assess it quick, but once you have that information, you've got to go to the next. We got to get to that next piece. And so for him, like really, he's pale. I like Tanisha brought up the pale. What else causes us to be pale?
Not getting blood perfused to a certain spot.
Yeah, that lack of perfusion. And so he's got something going on with perfusion. He's pale, he's thready, fast pulse. Level of consciousness, definitely a piece in there because we've got groans to stimuli. But again, that can be from our perfusion where they're not really awake. And I know it's hard to do this with a picture, but it's just challenging you to think. You can't always be like, this is the always, this is what it's always, you know, because that's like if you get yourself stuck in that kind of thinking where it's always this, like it's going to be hard when you come into an emergency situation because it's not always that. Like you'll think, oh, it's this, and it's like, no, Mother Nature's going to tell you, make it look like something, and then it'll be something completely different. Rima, do you have a question?
Yes.
Okay.
So when we went to break room, I thought I was thinking about when you see someone first in an emergency situation, airway is the first thing they have to be breathing
Right.
to help them, right?
Right. But
Okay.
with him, you have information. You've done your initial kind of doorway assessment with him. So that's why I asked for him, what's your priority? Not for just walking into an emergency situation, but you are absolutely right. When you walk into an emergency situation, safety, airway, breathing, circulation is good to go. But for him, for Fred here, you know, one of the interesting things is one of the first things someone said was, I'm going to call 911, right? So not only are you looking at what's going on, you know you're not in a place to get them where they need to be, and you're going to have to wait 75 minutes for someone to get there. Also thinking about, when you're thinking about that kind of thing, 75 minutes, that may be how long it takes, but if they're that rural, you're probably looking at a volunteer squad, which is going to take longer because they have to leave work or they have to be woken up. You know, they're not just on the bus. They're not just on the ambulance. So they may have to go get the ambulance and come. So that may even be more time, especially in our rural, like our rural areas, right?
Yeah, I just changed information in my mind. I didn't think about, like, I had the information about him already. So
Yeah, no, this was like, what's Fred's priority? And so breathing, guys, totally not gonna, I don't ever want to stop, like, you know, we don't want to stop people from breathing. But when we're thinking about prioritization, when we're thinking about what's really important right now, well, I know he's breathing. I know he's minimally responsive, which tells me we've got maybe some sort of cognition issue. Groans to stimuli, okay? Pale and thready fast pulse. Ooh, something's going on with that pulse. Something's going on with him. You know, and we haven't really dove into, like, why is the home health nurse going out to see him in the first place? Do you remember why we're going out to see him?
His abdominal surgery.
Yeah, he's a post-abdominal surgery. So this is what a post-op bleed looks like. Somebody who's having internal hemorrhaging because their surgery came undone, right? They were fine, they're just not feeling real great, whatever. But you find them unconscious or minimally responsive on the floor, and it's because they're bleeding out from a surgery they had, you know, 6 days ago or whatever, and either they are a farmer and they went out to the ranch too soon and just did their stuff and ruptured it, or they you know, something just popped open, or a nick that was done actually ruptures open. So that's thinking about what other information would I want. Sometimes our hemorrhagic shocks they're not bleeding, like you can't see the blood, they're internally bleeding. So that's something we always want to be paying attention to. I heard somebody say something. Someone have a question? Okay. I have to like scroll through you guys because there's so many of you now. So that's just something you want to think about, is are they having some sort of shock? This is obviously there's shock. You know, what other things would I want to do? I might want to check a blood pressure. If I'm a nurse that's working home health, I might be able to be out there and be like, okay, I'm going to check a blood pressure. You know, I've got the stuff with me to do it. But how do we want to get him? What's our action? What do we want to do for him? We're just going to let him keep sitting here while we wait for 911 to get here?
No, should we like assess his movement? Like, can he move?
Okay.
Are certain areas, but like, I don't know, talk to him, ask him how long has he been down on the ground. If he can answer, ask him, do we know where he is? Assess that part of him. If he's able to like respond and help, then just start to ask him, like, can he move certain areas? Is he in pain in certain places? I don't know.
Okay. He's not responding to you.
Oh,
I'm worried about his head. Did he hit his head?
Okay. He could have. I don't know.
Am I looking at swelling?
Okay. Might have some head trauma going on because he might have hit his head. We have a thready, fast pulse. He's pale. How do I want to get him?
Stable.
How do I get him stable? How can I stabilize this guy in his kitchen as much as
Drop his
possible?
feet up.
Lay him flat.
There you go. I want to get him flat. I want to lay him down. Like what areas do I want to perfuse?
His lungs.
Okay, what else?
His head.
Okay, brain. I don't care about his scalp so much, right? Get his feet up. Yeah, I want to get blood flowing to heart, lungs, brain. Those are the three
Right.
things I care about, right? Because those things are all being affected. He is breathing, so we're good there, but he's minimally responsive, so we have a cognition issue. We don't have blood flowing to the brain. He's pale, thready pulse. So we've got all that stuff going on that's saying we've got some sort of perfusion issue. This is what a guy in shock looks like, other than not looking like plastic. But sometimes they do look a little plasticky. All right, so yeah, your priority action is, like, we've done our quick assessment. I'm probably calling 911 as I'm starting to figure out what to do. Okay, if you're a home health nurse, you probably have some supplies in your car. Not a lot, but you probably have some. So you could start potentially some actions. Maybe you have an IV start kit that you could start an IV on him and get him going, ready for the paramedics to get there. That just depends on what's in your scope of your home skill facility, your home care. So that one's kind of really blurry depending on what your policies are. But I have a tendency to be a little bit more like, well, I know we need to get this going. If I can get it going now, he'll be ready for the paramedics when they get there. So it definitely depends on what your facility policies are, but how much he's dying. Okay, so if I can get IV access going on him when the paramedics get there, they can get going. If I have oxygen in my car, maybe I throw oxygen on him. Maybe I get a pulse ox on him and see where he is. Because even though he's breathing, he may not be perfusing well, so maybe I want his oxygen a little higher. Okay, so those are some things to think about as you're going in, especially when you're a home health nurse, because you just kind of are on your own. I don't know if you guys, how many of you guys, and you can just raise your hand on the little like icon thing, but how many of you guys have worked as a home health aide or been in people's homes and done cares in their homes? Okay, so I got a few of you. All right, it's a very different type of environment when you're a home health person. Like, I did it for a little while. It's not my favorite, because rules are just a little different. Like IV sticks, we've learned that IV needles you use only one time. If you don't get it, you throw it away. But like, I know I had limited supplies, and if I have a hard stick, I may poke twice with the same needle. Does it suck? Yeah, but it's about what I have and what I have to get done. So it's not standard protocol, but sometimes protocols get a little wonky when you're in people's homes. So yeah, I want to get him flat on his back if I can, as much as I want to stabilize, because like Christine brought up the head trauma, like he may have hit his head. So I may still want to hold that C-spine and get him to lay down and get him flat. So stuff to think about as you're working with patients. What's your priority? Okay, not your priority for a generic priority list. What's your priority for that patient? So trying really hard to remember, like, what's my priority for that patient, not just a generic checklist. Nursing isn't generic. This is where we've got to start applying information we're going through. Okay, so Fred unfortunately is going to end up back in the hospital with another surgery to stop the bleed. When people have abdominal bleeds, a lot of times we don't see it until they get to this point. So all right. Let's go to our next patient here. Let's see if it'll go. Okay. All right. So you're a rehab nurse. Okay. And this is Sally. Sally had an ORIF of her right hip after she fell and broke it. She's in rehab to rebuild strength to go home. What more information do you want about Sally?
Who does she have at home to help?
She has, yeah, she probably lives alone. If not, her husband would be there, but he's equally as old as she is. Okay.
Can you
Home health set up.
scenario one more time? Because I literally had ran to the bathroom to find my charger because I'm on Zoom on my phone and it's done.
I guess I just read it. It's there for you.
Where? Oh, the little picture. My picture is of you, I guess.
Oh, yeah, no, the PowerPoint. Okay. So who's at home with her to help? What other things might you want to know?
Do we have home health set up?
Okay, if she's gonna go to home health. Okay.
How much improvement has she had?
Okay, how much improvement has she had? Look at the picture. How many hip fractures?
Why-
Huh?
Why is she crossing her legs?
Oh,
It's like not how she
Yeah.
should be positioned at all.
yeah, she's got her legs crossed. Nice catch.
Yeah.
By the way, the mannequin's feet are a size 7.
Oh, good to know.
If you ever need to know random information. So, but yeah, like she's got her legs crossed. Anybody else concerned about anything else that's going on with her?
She's
does she
sliding
have-
down.
Okay, she looks like she's maybe sliding down a little bit.
Mm-hmm.
Does she have anything like on for like sequentials, TED hose, anything like that for
Okay.
perfusion?
Yeah, maybe some, if we've got to have some perfume, something on. She had a hip fracture and she still has a Foley.
Yeah.
How long do we leave Foleys in after hip fractures?
Like 24 hours at the max, but like usually like 4 hours or something like that.
Right. Yeah, that Foley should be out by now. Like, she shouldn't have a Foley in, especially in rehab. Like, if somebody's got a Foley in, I'm wondering why they have a Foley.
Yeah, maybe it's like a pre.
Right. Is it chronic? A chronic one?
Right. Is
Yeah,
it a chronic Foley?
chronic
Is it
Foley.
not? So, nope, that Foley was just from surgery.
Does she have some fluid retention?
Okay. Does she have some fluid retention? I don't think so. She's not really puffy.
No.
I don't see any puffiness. See how dirty my windows are, though. Okay. So,
So why
good.
haven't they removed it?
Yeah, why didn't it get removed? Did it get forgotten? Did it, like, did she just whine and say, no, leave it in, I don't want to move, it hurts to move, you know? So, okay. So now, here we've got Sally. She's pale, she's not answering questions appropriately. She is cool, she just can't get warm. Her breathing is rapid and shallow. She is weak in all extremities. What's your priority?
I would assess her vitals,
Okay,
get like a quick temp and blood pressure and all that.
so that's your action, but what's your priority?
Perfusion.
Okay, so so starting into that perfusion piece of it. Okay,
Infection.
infection, worrying about some infection going on. Can people be cold and have infection?
Yeah.
Yes.
Yeah.
Can you have problems with sepsis and not have a temp?
Probably.
Yeah, probably. Like polio. Yeah.
There's a thing called
Yeah.
cold sepsis.
Neutropenic patients.
Yep, your neutropenic patients, they may not have a temp, right? Their body may not show. They may go the other direction. As people are crashing, they may go the other direction. So that's something to pay attention to when our little old elderly people start getting really cold. They can still have an infection, right? So we talked about priority with perfusion, and your action then is to take those vital signs. Priority of infection. So what are you going to do with infection? What's your action if you're worried about infection?
I don't know, notify the
Probably
doctor,
would do
get like a
labs.
blood culture.
Get labs. Okay. What kind of labs are you wanting on her?
Like a white blood count.
Oh,
Yeah,
Okay.
like a CBC and
Not just a CBC, but what do you want out of that CBC? That white blood cell count?
with differentials maybe.
with the-
Okay. Yeah, with the diff, so you can see what's going on. What else would you want?
What is it called? CRP. I want to know if there's any inflammation in there.
Inflammation. Okay.
I was gonna say a BMP.
What do you want out of that BMP though?
Well, you're gonna probably the calcium, potassium.
But what's your priority, guys? What are you worried about? We talked about infection, so the white cell count. What else is going on?
Would we want to look at her lactic acid?
Maybe. What kind of facility are we in?
Long-term, are we in long-term?
We're in rehab.
Rehab.
Do you have the ability to
Okay,
do a
don't worry
lactic
about
acid in
shipping
the
her somewhere.
Okay, what I want you to do, I'm
Stabilize
gonna leave this screen up. I want you to make that priority map again, okay? I want you to pick out what of this information is important, and then put off your concepts on the sides of it, and then let's kind of go through. We'll finish this Adele song here, and then when it's done, we'll kind of talk about it. So think about that priority map. What information is important? What concepts go off of it, and why? About 30 seconds left. Okay. So what information is important about Sally?
Not answering appropriate.
Okay. Why is that important, Lakeisha?
The change in her cognition.
Right. A change in her
Can I-
cognition. So
Can I, Aaron,
who else was saying something?
me, Catalina.
Okay.
I was thinking like I'll just jump like my priority little concept map. Like I started it, but then once I jumped to infection, I just went right away to the fact that she still has a Foley. Could she possibly have a UTI, and should we get a UA because that could be causing her infection and her confusion?
Right.
That's exactly what I put too. I said that Kath was in too long, which could be a potential for a UTI. So do labs and find out if there's any type.
Yeah. Remember
Yeah,
that.
get a UA. That could cause her confusion.
Yeah. Now, how do we get a UA with somebody who has a Foley in?
You can get it from the bag
From the
or like
bag.
the line. You can
No.
If you get it from the bag, it's going to show infection because bags are dirty and gross. Okay.
Get it from
You
the
got to get
line,
it from the tubing. Yep. From the line.
There's a little port.
Yep. There's a port on them. The other thing that you can do is sometimes we have to take them out and put a new one in, and we'll get a UA from the new one.
Or do
So
a straight
depending,
cap.
that's going to be depending on how your facility wants you to do it. But like you've got her, she's rapid, and so she has some breathing issues, right? She's got rapid, shallow breathing. She's weak. She's cool, which is kind of that, like, okay, maybe she's not totally on that SIRS protocol yet. Maybe she's not, you know, there, but maybe she is. And she's pale. Well, I mean, that's always a hard one. In Nebraska, we're all pale at this time of year, right? So, but usually you can tell when people start losing that pink in their cheeks. So definitely we've got some priorities going on. We've got, you know, perfusion is still really important, all right? Because when we're in shock, we're going to start going into bad issues. And I will tell you, I get more of these little patients and these little ladies in the ICU because people forget they have catheters, people don't do good pericares, or they just simply get UTIs so much easier. So that's something to really think about.
We get them too, Erin, where they'll come from the hospital sometimes with a Foley because they're either in so much pain, they'll refuse the bedpan, like they're old ladies that are so scared of the pain because they're not used to dealing with it.
Yeah.
They're so scared of it, they don't want to move.
Yeah.
They literally like, no, you know, like, oh my God. And they just cry and wail when yeah. So, I mean, I've seen them several times come from the hospital after hips with catheters.
Yeah. And so, and I mean, she's not helping her situation, right? Because she's crossing her legs. So she's definitely not helping her situation with the pain. But also little ladies are very private. So they don't let you get in there and really clean and get down in that tissue and skin folds and stuff. So that can be something to think about. It's not necessarily, you know, it's not pointing the finger at it's the hospital's fault, it's the rehab's fault, it's the doctor's fault. Like, it's like, who cares whose fault it is? Let's just take care of it. All right. I know we like to point fingers a lot and we like to judge, but yeah, the hospital, maybe they were like, yeah, she wanted the Foley, we left it in. They'll get it out in rehab when she's up and moving. But maybe she's been refusing to do cares.
I have another thing, Erin. I was wondering because just right away, from my experience, I know usually people who have like knee or hip surgery, like one of the big thing is clotting, you know, after the surgery, from like that blood, like, you know, all that was torn through the tissue, the blood are like not moving as much, the circulation. So I was wondering, like, when we do labs, will we check like a clotting factor?
I wouldn't necessarily check a clotting factor unless she was on something that made me curious about it. Like,
but for her age, would that be like, do you think that would be like a stand-in order from the surgeon to put some sort of because she doesn't have like any TED hose or anything like for.
So maybe she just maybe she doesn't have her TED hose on yet. So that's something, but so that's always good to keep in the back of my mind, but that's not what's going to cause her to be pale and not answering. Like, we have some sort of issue going on because
what if she has a blood clot? What if she has like a PE though?
So that's going to be causing the breathing, but not the answering questions and the weak and all, like that's not answering all of these pieces, right? A PE, absolutely, but then we're going to be having the rapid shallow breathing. You might have her be pale, but you're going to also have her be not responsive. So like, she's responding, she's answering questions, she's cool, she just can't get warm. The PE is not doing any of that.
Okay.
So, but yeah, I mean, not saying that that's wrong to think about, because it's not, but it's just in the back burner. It's not that like something else is going on, but your PE, you would be like, okay, what do I want to do for a PE? What's your treatment for, what are you going to be looking at for a PE? What kinds of things are you going to do? What's your action for somebody that you think has a PE?
Osculate their lungs.
You could? You're not going to hear much.
We'd be wanting to get her to a hospital and get like an X-ray of her chest.
Yeah, I mean, and an X-ray is not even going to show it. You're going to have to get a VQ scan. You're going to have to get, you know, like, we have to get a VQ scan. We got to get in there and check out the vascular. But your actions are going to be somewhat similar. You're going to get your vital signs, right? If her O2 sat is dropping pretty rapidly, you're going to know it's not a sepsis issue. We've got some sort of lung issue. So that's that digging. That's where not all information is going to lead you to Rome. You know, some stuff's going to lead you off to different areas. And that's that digging into information of, that's why you have to gather more information for her. Because she totally could have a PE, but what we would be worrying about then is then either way, we have to stabilize her and get her shipped out. So with a UA, you know, that catheter being in there for a prolonged period makes me just concerned, because now we have a confusion issue that wasn't there before. All of a sudden, they're not answering questions appropriately. You know, she's cool, can't get warm. So, but yeah. So it's good to always be thinking about those things. I think Catalina, especially because you come from the hospital where you guys really worry about PEs a lot, she would probably be past, if she's in rehab, she's probably past the initial PE worry, you know, because she's already out in rehab. So she's probably past, because usually our PEs come, I want to say, like sometimes they come literally right after surgery, but she might, you know, usually you're 24 to 72 hours, PEs are going to be thrown, at least for post-op stuff, I would think. Most of the ones that I've seen are pretty rapid. So, but not saying that we can't get some, we might have some DVT action. You might want to be like, hey, does she have Lovenox going on? So, or is she getting up to rehab? Is she getting up for physical therapy? So you can see how like information, that digging is really, really important. You have to dig into what's going on. I just saw a former student post, she had a really bad night at the hospital, or really bad night. I'm pretty sure she works at the hospital, but I guess I don't know for sure. And she said, it's amazing how much, if you pay attention to changes, you can catch, right? You know, and so it's just really cool to see her use how this stuff works. Like, pay attention to those changes. Pay attention to what is going on. Start doing that priority mapping, guys. Start practicing it, because I promise you, it will help you. And when you're working on a test, you can be on your piece of paper, drawing out your priority map. When you're working with a patient, you're starting to already, eventually you get that to where you don't have to think that way. But if you're always, you saw like what happens when you always go to airway, well, the data doesn't support that. The data's fine. I remember I had a test question a while ago, and people put that I needed to put oxygen on the patient. And it's like, your patient's 98%. You don't need to put oxygen on him. He's fine, right? It was what was really important, what really needed to be done. Pay attention to your patient, okay? So make sure you're assessing that patient. So, good, okay. Stop sharing. All right, what other questions? We've got about 20 minutes to kind of wrap up this whole unit. What other kinds of questions do you guys have?
Erin, for the muddy thoughts questions, when Emily asked about the percentage about rounding,
yeah,
and it said like the 31.5,
right?
In that situation, would we round,
yeah,
or should we just do it as is?
I thought I answered it, and I said, yeah, I checked with Rachel, and she said since it's like estimate anyways, and that's kind of what I was thinking. Since it's an estimate anyways, you would round it, and you would round it up every time, because it's going to be a 0.5.
Okay, I just didn't know if it was like that specific situation or every time. So I wanted to double check.
Because with the rule of nines, it's going to be an estimate, so it's not always. So that's something to think about, like how, if you mean 0.5% isn't going to matter that much. And remember, fluid resuscitation, that is just a guideline of how to do it. Like, it's not a have to, it's not a like you're going to titrate depending on urine output and pressure, but that at least will give you an idea of where to start.
Okay, thank you.
I got a question, Erin.
Yeah.
For head traumas, do we put them on fluid restrictions? And can you talk about medications, common medication that we use?
So, okay, it depends on the head trauma. So if you're trying to dehydrate them, so like if you're talking a concussion, you don't necessarily put them on a fluid restriction. You just don't want them necessarily drinking a bunch of water. It's what are they drinking, not how much. You don't want them to have a hypotonic or an isotonic solution. You want them to have like the Gatorades with all the electrolytes. Like maybe you have the Gatorade powder, and so you make it a little bit more concentrated than it would be. I remember we had
Gatorade is hypertonic, right?
We want them to have more hypertonic solutions, or maybe you let them, like if you have somebody that's like my mom, not necessarily had a head trauma, but she hates water. She doesn't like to drink water. She likes to drink stuff with flavor. So like for her, we always give her like the Gatorade, or something like that, and give her, or no, never mind. Yeah. So we'd always want to give that extra flavoring or something in it. If people love water, then it's the opposite. You're trying to figure out how to balance, like, okay, you can have a glass of water and a glass of Gatorade, or you know what I mean? Or so that they're not just getting a hypotonic solution. Meds, it's just that, like, we don't really have meds necessarily for head traumas. There's nothing, I can't give you an aspirin to fix your head trauma. We are giving, like, that's going to be the meds that we do to treat symptoms. So
speaking of aspirin, if someone has head trauma, are you gonna and they are already on aspirin or anticoagulant, do you stop the anticoagulant?
Yep. And then if they have AFib, they're gonna throw clots and they're gonna stroke. So it's a really big conundrum. Like you're balancing one for the other. But you think about, you get patients that have a head trauma and they were on Eliquis. Well, now they just became a massive head bleed. So that's always a really hard thing to do, because you can't, a lot of our anticoagulants don't have antidotes. Coumadin does. Vitamin K is an antidote for Coumadin. I think there's one other one that has an antidote, but all the other ones, because they're all so new, they don't have antidotes. So now we have patients that we give all these anticoagulants to not have strokes and not develop clots in their heart because they're AFib, and now they fall down and they hit their head and now they bleed out. So, and it's hard. It's part of it's the risk. No medication comes without a risk. No medication comes without a physiological cost to the body. So, but as far as like med specific, you got your anti-seizure meds, so your Keppra, Dilantin, Nimitok, Ativan, Valium. Those are all like your anti-seizure meds that we give to keep from people having seizures. So it's kind of interesting. What other questions you guys have?
I have one for seizures. So like from the videos that I watched, like that you gave us, like, so for seizures, like you basically just like let it play out.
Yep. Yeah, there's no, I mean, you can give Ativan, like that's kind of a fast one. Sometimes they'll have Ativan suppositories and stuff. So if you don't have IV access, you can do like a lorazepam or a Valium suppository kind of thing. But yeah, you can't stop a seizure. That's like trying to stop AFib. You can't stop it. It just is. So we have to treat the symptoms and keep them safe while they're going through it.
And it's just identifying, we just have to know to identify like the certain types of seizures.
I mean, you can. I personally am not a huge one for identifying types of seizures, other than because if you want to go back and listen to like the head trauma lecture, I talk about a nurse that documented very poorly and the consequences that it causes. So making sure that you document appropriately versus being able to necessarily identify.
Labeling it, yeah.
Like myoclonic, that's muscle, and clonic is the tightness. So I mean, if you know the breakdowns of the words, you're okay. Absent seizure, they go absent. I mean,
yeah.
Partial seizures or localized seizures, those are seizures in a specific spot where you're going to see them have a reaction from it. So that's kind of, I mean, if you want to do Diceribet and all that, great. I mean, it's just how deep you want to go down that seizure rabbit hole, but make sure you're documenting what you see.
Okay.
So, what other questions you guys have?
I guess I'm just kind of like looking at your modules and just peeking in and seeing what.
Well, hopefully you've done them.
Yeah, I have them I'm just looking at them right now to see like what question, because I lost my folder that I took notes on. It's my daughter put it somewhere, but she sleeps still. So I was just trying to like remember like what kind of questions I had, but I don't remember having a lot of questions.
Okay.
Anyway.
Yeah, you work in the hospital. You're used to those emergent situations.
I mean, can I just tell y'all about a situation yesterday?
Sure.
It's kind of unrelated, but we had 2 different people come in with foreign objects in their room yesterday. Never in my life have I seen this. 2 people came in, foreign objects in their rectum. One of them had a 6-inch dildo and lodged in the rectum. The doctor got it out and the dildo was just sitting over on the counter.
Hold on. Wait a minute.
Yeah.
Yep.
Yep. Different types of emergencies.
Both of them were men. So here's another one, and I was like, oh my God, like what can go bad from this? But there was the second one that came in had a mango up there, and then they tried to get it out with a corkscrew at home. So I was wondering, like, that just sounds like that can cause some sort of or like wouldn't your body like respond to that in a shock type of way of like something that big being inserted? No,
it won't respond in shock until you go septic, because
I'm saying like wouldn't it be
either
like
backed it up or you perfed something.
But like a mango, just think of the size of a mango, you know, like I just felt like, I don't know,
Adelina, people put all sorts of things in there.
It's my first time coming across this.
They actually have a apparatus that takes light bulbs out because they had to develop something to take light bulbs because people would put light bulbs in door handles and stuff like that.
I was gonna say soup cans. I've seen soup cans, not me myself personally, but
yeah,
I've seen like soup cans and gerbils and carrots.
Yeah, people get real creative. So yeah, but that would cause like a sepsis issue if you perf the bowel or if you doing the corkscrew.
The corkscrew, like that's what I was thinking too. Like you stick a corkscrew in there, I'm pretty sure you're in there ripping and tearing up something. Something's bleeding. I don't know.
Yeah, I mean, definitely causing some issues with that. So yeah, I've seen, I mean, probably some of the weirdest stuff is stuff that people put in the penis itself. So yeah, I mean, if you've got an orifice, people stick stuff in it. I mean, kids stick peas up their noses, so
they're children.
Right,
they're kids though.
Right.
This was a 51-year-old male who came in with a dildo, and I'm just like, that's embarrassing.
It is embarrassing, but
both of them were males.
Yeah, it happens. To each their own. And probably the 20 times he's done it before that, he's been able to get it out. That one got a little slippery.
But I was just like, I mean, I know it's like a vacuum, but like, you know, I was like, because the guy with the mango was like, he was kind of, because they said that they were going to have to go in laparoscopically. So he was like refusing it at that point. But I was just thinking like, so obviously like he's going to be like backed up. Like if he was to like completely refuse treatment or like if he was not to come home at all. I mean, if he was not to come at all, like wouldn't that create like a, I mean, obvious like blockage because it'd just be a big mango blocking.
Well, hopefully eventually his body'd be able to break it down enough that he'd be able to poop it out and pass it.
Like, you know,
really? But you don't know. I mean,
but you know, like when your body starts like prepping for a BM where your anus is like, or whatever, wouldn't that at some point start pushing that
I would think so. And as the mango like I mean, honestly, as the mango ripens or rottens, like it's gonna break down and get soft and eventually be able to come out. The dildo, not so much. So the dildo usually causes more problems with those kinds of things. So I mean, it's just use toys that are meant for that so that those problems don't happen. But
Yeah.
you know, I mean, welcome to nursing, guys. You're gonna see stuff. You're gonna see people in all sorts of awkward situations and embarrassing things where they don't want to come in and get help, but they need it. And so luckily they came in, because that would suck if you die because you got something stuck in there.
Right.
Erin, have you seen that show?
How long that man probably stayed at home before he came.
Right.
Yeah.
So, and then there's some people that just come into the ER because they have some psych issues, and so they like to have that attention. So that it's an interesting world. Welcome to nursing. So from shock emergencies to apparatus retrievals. So I mean, it's just kind of everything in between. But any other questions about shock, head trauma, seizures? I mean, I feel like we've covered it all here in this unit. Putting it all together, just really remember, guys, as you're going through that, think about what is my priority. A couple other quick notes before we wrap up. The AM test and the PM test will be different. So I'm going to end up doing 2 exams so that they're different. Just kind of a heads up. The other thing is make sure you sign up. And I don't exactly know how it looks on your guys' side, but make sure you sign up for, I don't know if it's on the calendar. I had to go through the calendar to do it for AM or PM. I don't know if it sent you an email. I don't know what it looks like on your side.
So we were trying to figure it out last night, and Asia had sent a video, and on her calendar it gave her the option, but on my calendar it does. I don't even know where to find the notification app for it. But yeah, my calendar and her calendar, hers gives her an option. Mine doesn't at all.
Have you refreshed? Because I noticed like mine didn't for a long time, and then I had to refresh it. And then once I refreshed it, it popped up. So I don't know if you need to change browsers or if you need to change, because I know Ashley's done one too for exit interviews. So if you haven't seen a thing for exit interviews, and really take some time when she has you fill out information, really take some time to fill out information on that so that you can give us feedback about it, because that's really important. We use that feedback a lot to grow and to make our program better. I know this has been a huge challenge switching from face-to-face to all online, but you guys have done really well. Just make sure you're getting in those modules and doing the videos. I think last I checked, it was like 7 or 8 people had watched the videos. So I'm going to tell you now, if you're not watching the videos and you're not doing the activities, you're probably not going to be real successful on this exam. So make sure you're getting in there and doing the work. I know it's hard. I know there's lots going on. I know there's kids running around. I know it's spring and beautiful outside. So I tried to keep them short so that way they'd make sense. Tried to really nuts and bolts it down to the important information so that you can be not only successful on a test, but successful at taking care of patients. So if you have any questions, keep doing the muddy questions thing. I'm going to look at it here later this evening and I'll get stuff answered. I will post a Quizlet up for review as well. Some of you guys are studying in groups. That's awesome. That really, I think, helps you, especially in this unit, talking about different experiences you've had. How would you take care of that patient? Just remember, it's not going to be a clean-cut answer. It's not going to be safety, airway, breathing, circulation. Like, you have to look at the data you're given and figure out your priorities. So not all emergencies are the same. They're all just kind of different. Put all those pieces together. Start reviewing, like, you know, your ABGs, diabetic ketoacidosis, you know, what kinds, you know, your pregnancies. Like, this is an all kind of encompassing unit. This is everything you guys have studied. What have you always worried about? You know, like stroke patients, what's the next thing that I'll worry about with my cardiac patients, what do I worry about? With bowel obstructions, what do I worry about? You know, we talked about UTIs. Well, yeah, UTIs aren't a big deal as long as we get stuff going right away. But once we don't, then we have big problems. So think about, always thinking about what's the thing I'm worried about the most. I know you guys always laugh on that paperwork in clinical of what's your biggest worry? And everybody puts death, and it's like, okay, but what's the death from? Let's prevent what the death came from. Okay.
Erin.
So yeah, Jen.
That sepsis video was hilarious.
I know, isn't it great? I love it. And
Yeah.
it's got
The what
good
video?
information in it. The sepsis one.
Yeah.
The music
It
video.
was good.
Oh,
Yeah.
yeah.
And it's got great information. Like Rachel and I were like, holy cow, that follows everything.
And I remember that way. It's fun.
Mhm.
Like, I'm a weird learner. Like, I can remember if it's like fun and like.
Yeah, it's a fun one. It's one that it makes me giggle every time I watch it. So
And I love
also
Justin
don't forget
Timberlake, so
when
that's
you the assignment that you did this morning, like the activity we did, make sure you take a picture and post it in that assignment box.
I missed another activity.
So-
What
activity did we do this morning?
Okay.
What you talk? We don't what?
Yeah, because it was an assignment. That was an activity that was done first thing at 9 o'clock. Actually, it was done at like 9:05. I'll post a video and you guys can do it on your own. But so you'll see an assignment tab in.
Oh, what did you do? What did you assess?
What did you assess?
Yeah, and so I'll post the video in there, and you guys that weren't here can do it too. But yeah, for the people that did it, you just take a picture of it and post that picture in there, and it's good. So
I still can't find the link for the test for Thursday. So if we don't
I
find
can't
it,
either.
we just log in day of the test, or what's the
if
process?
you can just let me know like which one you're gonna do, so that way I just have an idea of how many numbers I have.
Erin.
So
What are the options?
it's either 9 a.m. or 5:30 at night. So because I know people had like kids and they needed to shift kid care to later. So
Erin, do you need it in like an email form, or can I just let you know I'm doing 9 a.m. Thursday?
That's
So
fine.
I don't have to sit here and drive myself crazy trying to find the link.
Yeah.
Yeah, I think I inboxed you and told you my time because I was like literally sending videos back to back to Asia. Like, this is what mine says. She's sending me videos. I'm like, mine isn't like
Yeah.
that. So like, I'm
Yeah,
gonna
I
try
don't know. It always looks different. So it
Yeah, I
definitely looks different on my side.
I can't find it either, so can I just tell you at 9 a.m. too?
Okay.
I'll do 5:30.
Okay.
Where's my calendar?
9 a.m. is good for me, Erin.
Okay, thanks, Christina. All right. Yeah, so if you guys want to look at your schedules, you can, and we'll do that real quick. All right.
Hey, Erin, can I do morning?
Yeah.
Thank you.
Uh-huh. All right, guys, I need to
5:30.
5:30. Okay.
Erin, can I do 5:32? This Jen.
Yep. Jen, Lakeisha.
Sorry.
All right, guys, have a good afternoon. And for the ones that I'll see later this afternoon, I'll see you later this afternoon. I will get this uploaded and recorded so people can use it to help study as well. So.
I think Jen said 5:32.
Huh?
I said Jen just text 5:30.
Okay, got it. Thanks, guys. Have a good afternoon.
You too.
If Ani, do you just want to stay in here? Lakeisha, I'm gonna kick you out, okay?
Oh, I'm going.
You're
Sorry.
fine. Are you, I didn't know if you're, there we go, okay. Ifani, are you there?
Yeah, I want to connect my phone because my internet is having a problem.
Oh, here, Ifani, actually, I'm gonna go to the other meeting that I sent you because this is still recording.